Listo? Okay, so we're on. So it's my pleasure and honor to present Professor Jean Louis Vincent. Professor Jean Louis Vincent is professor of intensive care medicine at the University of Brussels, past president of the European Society of Intensive Care Medicine, past president of World Federation of Intensive Care and Critical Care Societies, and I would like to say my personal friend and teacher for many years when I was in Brussels. Professors, thank you very much for joining us. And we are looking forward for your presentation. We've had a lot of people following us in the social media asking for your presentation. So we are very glad you to be here. Thank you.
Muchas gracias. Buenas tardes. And many thanks, Carlos, for inviting me to share some thoughts about COVID-19. I'm sorry for yesterday. It's my fault. I did not really realize that it was at 7 o'clock. I thought it was 2 hours later for me. It's my fault because otherwise everything was very clear. And it was a pleasure to have Carlos with us in Brussels, and he worked in part on prospective randomized controlled trials with a paper published in Critical Care Medicine that made a lot of impact, showing that it's very difficult to show that anything works when we do prospective randomized controlled trials in heterogeneous patient populations. Now we will speak about a specific disease, about COVID-19, due to a specific virus. And I will emphasize that we do need prospective randomized controlled trials in this context. When we think at COVID-19, we think at respiratory failure due to a bad pneumonia. So I took this paper, which does not bring much new information. It is primarily a paper on epidemiology of severe COVID-19 in northern Italy when they had their terrible epidemics. And it shows that many patients are elderly, as we all know. They are severely hypoxemic. We can see the PF ratios that are commonly around 100 to 200 millimeters of mercury. And these patients often require high FiO2s and sometimes high PEEP levels. We will go back to that. So I'll start right away with some management aspects, because if it's primarily the lung, which is really attacked by the virus, then the V of the VIP should, of course, be applied first with oxygen administration. And the question, should I intubate the trachea of that patient? Otherwise, we will speak about fluid administration, about the maintenance of an adequate cardiac output, sometimes with the use of inotropic agents. Now, of course, we start with oxygen administration, and when required, with non-invasive mechanical ventilation, and we have now modern masks that allow us to do it. Of course, we are concerned about the projections of droplets, aerosolized particles. So we may consider helmets, like in Italy. They like it very much in Italy, where patients could breathe in a relatively closed environment. Now, these slides, of course, are not related directly to COVID-19 patients, but the measures are these ones. And we have even developed new masks limiting the risks of projections in these patients who are treated with non-invasive support. Well, we already knew that prone positioning could be used in severe respiratory failure. This is a paper already published several years ago on this, and more recently, before COVID-19, of course, in 2019, there was no report on these patients, but even in severe ARDS, we could combine high flow nasal cannula oxygen administration or non-invasive ventilation and put the patient in prone position. This is another paper from Perez Nieto showing how we could put patients in prone position even when they are not invasively ventilated. But this has been described more recently in COVID-19 patients. The same thing. There is no reason for COVID-19 to be an exception to what people had reported before. Now, importantly, we should not intubate the trachea too late. Sometimes we are concerned about the risks of endotracheal intubation. We are concerned that it may be difficult for one reason or another, and we may postpone the use of invasive ventilation. But that it's a very dangerous exercise, because if there is a respiratory arrest, there may be a cardiac arrest as a complication, and this may be terrible. So it's not only the gas exchange that should be taken into account, but the degree of dyspnea, the respiratory rate, the way the patient speaks, the degree of consciousness that should be taken into account to decide when to intubate the trachea of these patients. Now, and I return to that in a moment, there are some other factors that may influence these decisions. Of course, we need to have available equipment and available personnel. If there is no bed available, if there is no respirator available, it may be very bad. But there are also some ethical decisions that had to be applied in China, they had to be applied in Italy, they had to be applied in Spain, in Madrid in particular, in France, in Mulhouse in particular, when there is an excessive number of critically ill patients, there may be some aspects that could limit what we could do. But also there are some limits in what we should do. If it's an elderly patient coming from a nursing home with comorbidities, perhaps dementia, maybe we should not apply invasive mechanical ventilation. I return to that in a moment. I'd like now to focus on the type of respiratory failure, because initially people were focusing on the ARDS, thinking COVID-19, when it's bad, it's ARDS. Well, what is ARDS? It's a syndrome. It is an entity that we constructed. It's not a disease. And if you go over our Berlin criteria, well, we decided that the ARDS should be acute. It's acute respiratory distress syndrome. But in COVID-19, these patients have been ill for at least 1 week, if not more, when they develop the severe respiratory failure. So they may not need the criteria that we proposed. But more importantly, when we started to do CT scans, we realized that it's not the typical pattern that we see here at the right-hand side. Initially, it could be localized, usually in several places, or as in the bottom here, it could be at the bottom of the lung, in the posterior parts of the lung. So our Chinese colleagues started to describe what the radiologists call ground glass opacities, which can be typically observed in different types of diseases, including different types of viral pneumonia. And so I will not go over the details of all this, but we started to realize that the pattern can be variable and include different abnormalities that may change over time. Look at these pictures. Day 3, localized. Day 7, it extends. 11, it expands further, and then hopefully it gets better. So the aspects are pleomorphic. You can see the ground glass opacity. You can see what the radiologists call the crazy paving pattern, or there could be consolidations with even holes in it and reverse halo sign. And this changes over time as reported in different studies. So you can see here various CT scans of patients with established COVID-19. There are some aspects which are the same as in other viral diseases, but some aspects may differ. There may be less pleural effusions than with other viruses. There may be less lymphadenopathies than with other viruses. It may be more peripheral. But okay, so we can see a number of things and nothing is very specific. That's how we should not make the diagnosis of COVID-19 only on the basis of a chest CT scan. Now, if the chest CT scan is entirely normal, then the viral pneumonia is indeed very, very unlikely. And it's only in the most severe cases, usually some days later, that we see a more typical ARDS pattern with bilateral infiltrates as we see in other types of ARDS. So in COVID-19, there is severe hypoxemia. It may not be so acute. It's not always bilateral chest infiltrates. Cardiac filling pressures may be increased, but in some ARDS cases, it may be the case too. And compliance is not always decreased. Initially, at least, the lungs can be ventilated relatively easily. So the airway pressures do not increase so much. And it's perhaps in part for this that dyspnea is usually not so evident. Patients do not have tachypnea, probably because the thoracopulmonary compliance is not very much reduced. So when we manage these patients, we must be careful not to reduce the tidal volume too much in the early phases, although we now always limit tidal volumes. So that's not the major aspect. But the major aspect is that we should not increase PEEP again and again because there is severe hypoxemia. The severe hypoxemia may not respond so well to PEEP. We may actually have some hemodynamic compromise associated with excessive PEEP administration. So that's how Luciano Gattinoni proposed to describe two types of respiratory failures associated with COVID-19, a type 1 viral pneumonia and a type 2 ARDS type. In the type 1, we should not apply PEEP generously. In type 2, we treat the patient as we treat any ARDS. So ARDS is just a syndrome, and we must be careful not to focus too much on ARDS as if it was a disease. Now, very importantly, when we hesitate about endotracheal intubation in patients would be treated with endotracheal intubation when there are no therapeutic limitations. We need to look at the respiratory drive and the inspiratory pressure and this inspiratory effort of the patient. Because if there is a quite strong work of breathing, there may be what we call SILI, self-inflicted lung injury. And that would be in favor of endotracheal intubation. So when we decide to go from non-invasive to invasive mechanical ventilation, we need also to evaluate the risk of SILI associated with respiratory efforts. Now, if the patient is invasively ventilated, there is still a risk of SILI if the patient is not well coordinated with the respirator, and then we may use sedation and paralysis. Now, the implication of this is that we should not ventilate all COVID patients with deep sedation and paralysis. No. I heard people saying, yeah, in COVID, yeah, they are all sedated and paralyzed. No, that's terrible. Think at the long-term complications of the disease. So if the patient is well adapted to the respirator, use minimal sedation or no sedation at all, and do not use paralyzing agents. So what kind of prospective randomized controlled trials we need here, I don't know. But at least we should personalize our therapies. And if you come to Brussels next March, we will have an entire roundtable conference on this. What are the limits of ARDS and sepsis? Does it really help to say that the patient is ARDS? There is no specific treatment for ARDS. Corticosteroids is debated. So there is no specific treatment whatsoever. And mechanical ventilation will not really be very different. Okay, let's move to organ dysfunction, because COVID-19 is not just pneumonia. It is an endotheliopathy that can concern every single organ of the body. So when we speak about organ dysfunction, we speak essentially about the 6 organs, and we already spoke about the lungs, but we could now speak about the circulatory system. Many of these patients can have shock. Now, it may not be very severe. It's usually they do not need very high doses of vasopressor agents, but it needs to be treated. And you can find any kind of shock, any kind of mechanism, being hypovolemia, pump failure, obstruction, or distribution. These patients are often hypovolemic because they were dyspneic, they had fever, sudation, they may have some edema formation, and when they arrive, very often the doctor thinks, oh, there may be RDS, let's restrict fluids and give diuretics. May not be such a good idea. I return to that in just a moment. They can be cardiogenic elements. The Chinese colleague spoke about acute cardiac injury, which is not well defined, except maybe by increased troponin levels. But we know that this is not very specific. We don't know what to do when the troponin levels are increased, unless there is a coronary syndrome, of course. But in most patients with COVID, it is not a coronary syndrome. They may be myocarditis and sometimes arrhythmias. Now, as I say, there is an endotheliopathy with often coagulopathy and microthrombi or macrothrombi, pulmonary embolism can occur. And there are some cases of profound shock due to massive pulmonary embolism. And then, of course, they can be this cytokine storm, a lot of 3-TNF, interleukins, etc., being released, and this can result in a septic shock-like type of situation. So the cytokine storm involves many cytokines, like in severe bacterial infection. So could septic shock be viral? Usually we say no, it's typically bacterial shock. Well, not with COVID. No, there could be viral shock associated with the massive cytokine release. So shock, myocardial aspect, hypovolemia. Let's consider cardiac output. It's essential to maintain enough oxygen delivery to the organs. And now when I speak about cardiac output in particular, I go back to some of the same elements. Preload, let's be careful about hypovolemia, contractility. Afterload can be massively increased if there is pulmonary embolism, and heart rate if there are arrhythmias. So here we don't speak about the peripheral vasodilation, because vasodilation helps the heart. It does not hinder cardiac function. Again, the cardiac injury described by our Chinese friends is a bit hard to understand, because I think that in some cases they described a situation where there is an abrupt collapse following endotracheal intubation. So that suggests that there is hypovolemia, and this is revealed by the increased intrathoracic pressure associated with mechanical ventilation. So you see the point. Edema may require fluid limitation. I don't speak about fluid restriction because I hate the word restriction. But at the same time, hypovolemia could lead to shock. And if shock is treated by vasopressors, that's terrible, because we may miss the increase in cardiac output that may follow the correction of hypovolemia. So diuretics can be dangerous. Fluid challenge may be necessary. Fluid challenge. I didn't say fluid administration should be liberal. No, we must be very, very careful, but we should avoid severe hypovolemia, especially if the patient needs vasopressors. So we must remember the fluid challenge technique. We give just 100, 200 cc's of the solution we decided to give. I have no time to discuss it in detail. We have a clinical objective, and we need to measure at least the central venous pressure as an alarm signal. Of course, central venous pressure can be increased in acute respiratory failure, but we can look at changes in central venous pressure during the fluid administration. So this is not 1 liter in 30 minutes. That's not a fluid challenge. That's a lot of fluids. It should be a test, 200 cc's in 5-10 minutes. If the patient seems to improve, if the blood pressure increases, you may repeat it. And as soon as the patient stops improving, you stop giving the fluid. You may have to repeat it, of course, after a while, to measure the effect of fluid administration. Sometimes the blood pressure may not increase very much, but you could look at VTI by echography, which is a surrogate for basically stroke volume. Now, you may wish to use passive leg raising, okay, but do you know how to do it? I see too many people saying, I do a passive leg raising test, and I see immediately. No, when I ask them to do it, I realize they don't know how to. You don't just raise the legs. You need to monitor stroke volume very, very closely, because it's a very transient increase in stroke volume that you will see. So, wrong management, restrict fluids, give diuretics. We need to be conservative with our fluid administration and stop fluids if the patient does not respond. That's true in any form of ARDS, and that's true when there is some lung edema associated with COVID. Now, if the heart does not respond to fluids, but if we feel that blood flow is not sufficient, we cannot really do very much about heart rate, and we cannot really use vasodilators very much in this disease. So a bit of dobutamine may be indicated, especially if the SVO2 is low. That could be a clue to give dobutamine or a transfusion if the hemoglobin level is low, especially in elderly patients who may not tolerate anemia very well. So think at the administration of small doses of dobutamine, just a few micrograms per kilogram per minute. If there are excessive heart rate changes or any arrhythmias, stop. But again, it's the test, the dobutamine test. And sometimes you see an improvement in peripheral perfusion. You can even look at veno-arterial PCO2 gradients, but I realize that time is running and I'd like to move on. Just emphasizing, if you like, you can go back to our paper here with Daniel De Backer in CHEST recently, where we say that we can really use the central venous oxygen saturation to help to guide our therapies. And the veno-arterial PCO2 gradients could also be considered. Now, when we speak about organ dysfunction, we can consider that the coagulation system is, in a way, an organ. And this is what happens in COVID-19. There is an endotheliopathy combining inflammation and coagulopathy. And the combination of the two can affect any organ, not just the lungs, but also the heart, as we spoke about, the liver, kidney, whatever. Look at this paper just published 2 days ago, 3 days ago, beautiful, where they showed how the lungs can really reflect this endotheliopathy in patients who died, as it is an autopsy examination. Like others, we recently showed, this is not published yet, but patients with COVID-19 can develop thromboembolism, pulmonary embolism, usually not too severe. We diagnosed some by CT scan. The kidney can also be affected. I already spoke about the reduction in blood flow, but there are some renal elements. The virus can be cytotoxic. The immunological injury can affect the kidneys. And again, they could be microthrombi, microangiopathy. So renal failure is not uncommon. And this was also published in the New England Journal of Medicine, showing that you can find the virus in all organs, and you can find it in the kidney as well. And finally, to cite all organs, well, I could cite the liver. There are sometimes liver alterations as well, but the altered mentation can be also part of the picture, but it's not very specific for COVID-19. So, if organs can be involved, we could speak about viral sepsis. Exactly as for shock, sepsis is not always bacterial. It can be an infection plus organ dysfunction. That's what we call sepsis. So, indeed, in our recent guidelines that people called the sepsis 3 guidelines, I hate sepsis 3 because it has always been like this. Sepsis is an organ dysfunction caused by a dysregulated host response to infection. We didn't say bacterial infection. It can be viral infection as well. Interestingly, in COVID-19, there are not many super infections. We do not see so many bacterial infections added to the viral infection. This is just one of these papers just published or still in press, showing that only 8% of patients with COVID-19 have a bacterial or fungal co-infection when they arrive at the hospital. So it's not zero, of course it's not zero, but it's relatively rare. So we should not give antibiotics right away. Now, finally, I'd like to say a word about mortality. Because globally, in ICU patients, we may have a mortality rate of 30 to 40%. In mechanically ventilated patients, it may go up to maybe 80%. But sometimes we are overwhelmed. I wrote this paper in critical care before the big crisis. And I said with Art Slutsky, imagine your ICU if you cannot treat all patients adequately. If there is a problem of justice, if you do not have enough ICU beds, enough personnel, enough respirators, what do? It's something much worse than when your ICU is simply full, as we all experience at one time or another. So I just published this paper with Jacques Creter, emphasizing the way we could organize our ICUs, trying to expand the number of ICU beds, trying to keep moderately ill patients outside the ICU, but we may have to avoid treating patients who are too old with too many comorbidities. They should stay perhaps outside the ICU and they would be likely to die. So we organize our ICUs to try to admit patients in the coronary care unit, in the recovery room, in the pediatric ICU, etc. And I'm not sure that I need to speak about this. You want me to emphasize the role of clinical trials. But in the past, at time of the Spanish flu, as it was called, didn't come from Spain, but we called it Spanish flu 100 years ago, people were dying in tents because there was hardly any oxygen available and definitely no respirators. But today we have the equipment with respirators, with ECMO machines. So if we do not have enough ECMO machines, again, this is a slide which is not related to COVID, but I like this slide because the nurse is smiling. She is not afraid of ECMO. And if she had a mask, you could not see the smile on her face. But clearly, if we do not have enough ECMO machines, what shall we do? Could we ask the factories to do more ECMO machines, as during the war, people had to do more weapons, to make more weapons, more planes? In Brussels, the OD cars, OD started to make some respirators, simple respirators. We did not need them in Brussels, but I told them perhaps to go to Spain because there was a tremendous lack of respirators in Madrid at that time, or to go to New York for the same reasons. There may be a lack of personnel. And if our ICU personnel is ill, and if we have to expand the ICU, we do not have enough personnel in any case, we may have to call on other people coming from other floors, people coming from the operating room, from the regular floor to help us in the ICU. And this is a very big issue. Importantly, when the ICUs are very full, we should not give a priority of COVID-19 patients over the others. That's something that some of our colleagues realized in Italy during the crisis. When they had a patient with septic shock coming in, they said, no, we have several COVID people, COVID patients waiting there. Well, wait a minute. We need to accommodate critically ill patients, whether or not they have COVID. So there are some important ethical limitations. Sometimes we need to deny admission to patients who may not benefit very much. This was in an English paper, but it was about a Belgian lady who was 90 years old. And she said very kindly, keep the respirator for the others. I had a good life. So we need some form of triage. It's not easy. It's not only age. It's more life expectancy. For how long do you think this patient may live? And we may really explicit these criteria. They should be transparent, but they should also be consistent in the department. We should not say, oh, tonight it's Dr. So-and-so who is on call, so it may be easier to get a bed than when it's the other doctor who is on call. We may have to use scores in part, as the North Americans use the SOFA score for this purpose, but we need to have a team leader for this. And very importantly, we may have sometimes to stop therapy when the ICUs are full and some other patients are waiting to come here, to come in the ICU. This is a very nice paper in the New England Journal emphasizing that we should not say that the ICU is full, therefore we can no longer admit anybody. While if you can transfer the patient to another institution, you may consider that, but very often all institutions are full at the same time. The first come, first served basis is wrong. You can do it for transplanted kidneys because if you don't get your kidney now, you will get it later. But here it's a matter of life and death. And you should not penalize those patients who arrive after the first ones. So this is very, very important. If there are no respirator available, no ECMO available, we may sometimes have to take it from another patient. It's terrible, it's hard, but not doing it is unacceptable. So, if you like, we can speak more about this, but I think it's time to emphasize that for patients who are elderly, frail, with comorbidities, sometimes if we feel that these patients will die regardless of what we do, we should not start mechanical ventilation. We should allow them to die without pain. So that's a paper I wrote in the Lancet recently saying, you know, when we speak about death associated with COVID, let's consider a number of possibilities. Perhaps we decided not to start mechanical ventilation, or we started mechanical ventilation, but we decided not to start ECMO. So the patient died because we decided not to escalate. So people do not necessarily die when we have done everything we could, but we could not succeed. No, in some cases, we have to limit ourselves. So it's important when people die to record the type of predominant terminal organ failure. Is it the lungs? Or is it the heart? Is it something else? Is it the kidney? But we decided not to start renal replacement therapy. What is the proportionality of care in the dying process? Did we give up or not? And finally, what is the involvement of the COVID-19 in the dying process? There are some patients, I know someone in Belgium who arrived with a cardiac problem and he died of his cardiac problem, but he was tested when he arrived in the hospital and he was COVID positive. So is it a COVID death or is it a cardiac death? This is some kind of a funny picture. The skydiver who forgot his parachute was tested positive. So did he die of coronavirus? And finally, we need to support our healthcare personnel. And these aspects are also very, very important. But I realize that I have only a few minutes left. So I'd like to address the issue of therapies. It can go fast because really, there is nothing that works for sure. But this is a situation where we need prospective randomized controlled trial. It's a disease, COVID. Even though the presentation can be relatively heterogeneous, it's a single disease. I love this paper in the JAMA, reviewing the various therapeutic approaches. It's already getting a bit old. It was published 1 month ago. But this is my list that I published also a little more than one month ago. As you know, there is a lot of discussion, too much discussion around the globe about the hydroxychloroquine. Too much discussion, because the data have not been very convincing from the beginning. Well, there is a rationale, but it doesn't seem to work in patients. So also in the Lancet, with my colleague Fabio Taccone, we published this editorial saying, you know, where is the evidence for hydroxychloroquine? If it has a beneficial effect, it's very, very small, but it has also a small risk. So why would you give it? And now, a few days ago, this publication in the Lancet made a lot of noise because it's not a prospective randomized control trial, but it's a huge trial of almost 100,000 patients, 15,000 patients being treated. And what happens is that patients who received the hydroxychloroquine had a higher risk of death. And it was a death primarily related to myocardial problem, to arrhythmias. So even though it's not a prospective randomized control trial, it's a study added to what we had before. It's not the only one. It's a study added to what we had before, indicating that we should not give hydroxychloroquine. And now, hopefully, the French authorities have decided to advise against it. Remember, it started from France, from Marseille. Now, the CDC in the US has said the same. In Belgium, the authorities have said the same. Don't give it. Now, remdesivir is a perhaps more effective antiviral agent, and yet it's not very effective. This paper just came out in the New England Journal. You may say, there is something on the duration of the disease, a very small effect, very small, but it's there. The question is, will the drug company give it for a low price, or will they take advantage of it to ask for a lot of money? So there may be a small benefit, a lot of money associated with its use. Now, I won't speak about corticosteroids because right now we don't know when to use it, and the recommendation is not to use corticosteroids, except maybe in severe cases of ARDS, but then we are back to the question, corticosteroids in ARDS. But convalescent plasma is a very interesting option. It's an old trick. It was used many years ago. It's passive immunity. You take patients who were ill, who recovered, they have the IgG in their blood, you give the immunoglobulins to those who are acutely ill. It started with very small reports, but it makes sense. And the reports were very encouraging. Nothing compared to hydroxychloroquine. Here, there are some patients who really got better. So in many countries, we are very excited about this. In Belgium, too. I go back to my previous slide. If there is endotheliopathy, as I would call it, associated with coagulopathy, we would love to have this drug, activated protein C, that we showed can work in sepsis, but we could not identify the right patient. We could not identify the right patient with endotheliopathy and coagulopathy. The same is true with thrombomodulin. We do not have it available now. In Japan, they do, but you cannot get it from Japan. So unfortunately, we have none of these drugs available. We can only rely on heparin. We should probably be relatively generous with our heparin prophylaxis. In this paper in Press, that's been released very recently, they could show that patients who needed mechanical ventilation appeared to benefit from full anticoagulation. Okay, so if there is no contraindication to full anticoagulation in very severe cases, it's probably a good thing to do that, to try to prevent massive pulmonary embolism and to improve the microcirculation by limiting the formation of microthrombi. Now, there could be other treatments. Our Chinese colleagues would say that they have confidence in traditional Chinese medicine. Viagra is even tried. Yeah, there is a long list of things that could be tried. And here, colchicine in the UK, you may have your other therapy of choice. I think if you have an idea, you need to use it in a prospective, randomized, controlled fashion. Otherwise, we will never know. There may be a place for removal of mediators with purification techniques. And the companies making these filters make a lot of money today because people use them, but we are not sure that it helps. The idea is that with these extracorporeal systems, we could remove excessive cytokines in the cytokine storm in severe cases. It makes sense, but we do not have much evidence for this. So this is my last slide. We have written this in PLOS Medicine, which is a very good journal. We need to work together. In this case, of course, we wanted to work better together in Europe. We have not had a very good international collaboration. That's unfortunate. It's unfortunate. And we should share the challenge. And that's how it's so important for us to communicate, to speak about our experiences. I'll stop here. Muchas gracias.
So thank you very much, Professor. It is always a true a pleasure to hear such an international expert such as you with a very complete, let's say, understanding of all the possibilities. And I would really like to start the discussion by asking you if you think that mortality should be an endpoint in these randomized controlled trials regarding COVID-19 patients, because we see that in ICU trials, mortality is multifactorial, and people are it's very hard to reach a reduction in mortality. So what do you think that we should aim for other objective, maybe?
Yeah, that's a very good question. I'm not sure that we cannot reach an effect on mortality if we have a very effective medication, a very effective antiviral agent, or a medication that could really help the patient to avoid the cytokine storm, which is largely responsible for the multiple organ failure and the severe RDS. It could translate into a reduction in mortality. However, Carlos, I fully agree with you. We cannot take the mortality as an endpoint. But then you say, what are you saying? It doesn't make sense. On the one hand, you say you can reach it. On the other hand, you say it may not be the right endpoint. Precisely for the reasons I gave you, because there are a number of ethical decisions at the end of our lives. So that if we decide not to start ECMO in a given patient, well, the patient may not get the maximal treatment, and the patient may die without getting this maximal treatment. So I'm not saying we should not do that. I'm saying that there are a number of elements influencing our decision to give up. If the patient has been sedated, paralyzed for weeks, and sometimes we see that, and if the patient is almost 90 years old, we know that this patient will not recover. And so even though we may have an effective therapy, the game is over. It's really too late. So basically, the WHO has very nicely outlined the various steps in the disease, and it makes sense to look at the influence of our therapies on these various stages. Of course, the worst stage would be death, but before that, there would be requirement for ECMO and requirement for mechanical ventilation. So if we start a treatment before applying invasive mechanical ventilation, the need for invasive mechanical ventilation is a very valuable endpoint. If we want to start late when the patient is already mechanically ventilated, then we have no other choice than to take mortality, I'm afraid, but it may be too late. We should probably try to intervene before we need to intubate the trachea.
Very interesting, Professor. And in this same line of reasoning, I feel, and of course I'm citing your paper in critical care medicine, who to give these interventions to? Should we give it to the sickest patients? Should we give it to younger patients? Do we give it to patients who have more probability of survival? Maybe if we start early, we could have different results. Do you think that these interventions, as right now, I'm trying to think of the remdesivir paper that just came out in the New England a couple of days ago, which limits the stage, the time of the disease, but doesn't have any impact in mortality. So who should we give the full spectrum of treatment, and who should we try to limit a little bit more? Do you think that, what is your comment on this?
Yeah. Well, I presented the study on remdesivir, and I say that the effect is relatively minor and it will cost a lot. So I'm afraid I'm
Sí.
Corticosteroids are not very expensive. Plasma administration is not very costly. Of course, tocilizumab is very costly, but we would not give it. I didn't mention it, but it's one of the options. It's not given today except in clinical trials because we have no good evidence that it works. So the therapies will not be limited by costs. But as you say, there is the proper timing. We should not give them too early. I would not take corticosteroids if I had a moderate form of COVID-19, and I would not take anything actually. So we should, but if we want to see something that could be efficacious, we need to use it at the right time. Not too early, not too late. And the right time is usually a time of hospital admission. That's when we are worried. That's when the patient is admitted to the hospital. And that's where the patients are usually randomized for various therapeutic approaches.
Yes, we're receiving here questions from all around the world, and there's some questioning about the ivermectin. There is also some questions about vitamin D. Let's say ancillary therapies that could help these patients, you mentioned corticosteroids. However, we've seen these meta-analysis on corticosteroids that say that it's not too clear on the usefulness of corticosteroids. Can you comment on these co-ancillary therapies for such patients?
Yeah, I didn't catch the very first word, the very first treatment.
I think it's ivermectin that you said in
Okay. Oh, yeah. So yeah, the answer to all these questions is none of the above, none of them. Actually, you know what? I would even argue against paracetamol. And you know, some of my friends, you know, when they were ill, called me and they said, you know, Jean-Louis, I should take paracetamol and nothing else, right? I said, why paracetamol? No. Well, if you have 41 degrees, if you feel terrible, okay, take some paracetamol. But paracetamol is not a treatment of an infection, being viral or bacterial. It can decrease the host response to the invading organism. So don't take it. No, forget about this. So, so even paracetamol. Now, for all the others, yeah, you, as I mentioned, you could have the anti-IL-6 medication, the tocilizumab, or the anti-IL-1, the Anicra. You could consider other cytokine therapy. Well, first of all, we will not be able to give it because it's very costly and there are no indications for them in COVID-19. Well, you could try to find some tocilizumab, but I would recommend you not to do it because the evidence is really not there to support its use. So do it as part of a clinical trial. There are clinical trials on this. Go ahead and try to participate in what could be hopefully an international trial. It's so bad to see only national trials as if the virus was contained in one country. The virus is everywhere in the world, and it would be so nice to work internationally on this. Vitamin D, vitamin C, no, I would not. Well, if you like to take a bit of vitamin D, okay, go ahead. A little bit of vitamin C, okay, go ahead. But we know that this will not make a big difference.
Yes, yes, indeed. I would like to ask a personal question because I've been very troubled by some colleagues that talk about this fluid restriction in shock patients just because it's the COVID-19 patients. And you hear all around that you should be, as you said, restrictive of fluids. And I am very against that because maybe you are creating a path to multiple organ dysfunction if you restrict the fluids in patients who really needs it. So I would really like to hear again your comment on this because we're getting a lot of questions on this matter.
I think you said it very nicely. And that's the problem of people who focus only on one organ. And they have been told COVID-19 equals severe respiratory failure. And severe respiratory failure is due to lung edema, due to ARDS. So I need to limit fluid administration. Well, limiting fluid administration, yeah, that's a good idea. But restricting fluid, that's a very bad idea because as you said, we need to consider the patient as a whole. And we now really understand very well, better than at the very beginning, that COVID-19 is a systemic disease. It's a microcirculatory disease with coagulopathy, with inflammation all over the body. And we, I didn't mention that, but we, like others, have a number of autopsies. We have a paper submitted for publication on this, but showing that all organs suffer from the microvascular problem. So yes, we should avoid fluid overload. Yes, definitely. We should not pour fluids in these patients, definitely, but we should not maintain them hypovolemic, because hypovolemia leads to multiple organ failure and can exacerbate the cytokine storm. So we need to test the system. If we give fluids, if the patient appears to benefit, try a bit more. Let's see. Prudently try, but stop when the patient does not respond to fluid. If you see that the central venous pressure increases, but there is no increase in blood flow, there is no improvement in peripheral perfusion, the patient is not more alert, the heart rate does not go down, then stop it, then stop giving fluids. So we need to really personalize our therapies and individualize the needs for fluids. It's very, very important.
I couldn't help noticing, Professor, in your slides that most of your patients had a Swan-Ganz catheter. Do you think that we should monitor with using a Swan-Ganz, or should we use thermodilution, or should we use echo? What is your comment on this?
That's a very complex question, because it depends on the situation. And basically, we should use the Swan-Ganz catheter when what we measure can influence therapy. And if what we measure does not influence therapy, inserting the catheter can only bring trouble, but no benefit whatsoever. So sometimes it's important to visualize the pulmonary artery pressures when the patient is at risk of having right ventricular failure. Sometimes in pulmonary embolism, for the same reasons, it may be useful. It may be helpful to monitor left-sided filling pressures if we are concerned about fluid overload versus not enough fluid on board. If we want to have a very reliable cardiac output measurement, it's the most reliable method to measure cardiac output. If we are concerned about SVO2, central venous oxygen saturation, the mixed venous oxygen saturation is more reliable than the central venous oxygen saturation. And sometimes we need all of this, not in early non-severe cases. Usually we can manage with echo and virtually nothing else. When the situation becomes a bit more serious, we need a central venous catheter to have the CVP, not as an absolute value, but to monitor the changes in CVP during fluid administration. And the central venous catheter also allows us to have a central venous oxygen saturation, SCVO2. If it's low, it's a clue to indicate that oxygen delivery to the tissues is not sufficient. Look again at the hemoglobin level. If it's low, consider a blood transfusion. If the hemoglobin level is above 8.5, then you may use a little bit of the butamine if you think that there is no room for fluids any longer. So that's the basis for the hemodynamic management. And always make sure that the lactate levels remain within the normal value. And Carlos, your wife, Amanda Quintaqueiros, published a nice paper in Critical Care reviewing the time course of lactate levels over time. Very, very important. Some people speak about lactate clearance. No, it's not lactate clearance. No. It's lactate production and clearance, but production is more important than clearance. So repeat the lactate levels to make sure that they do not go up, but they go down when they were elevated.
Great. I know we have exceeded our time, but there's just one last burning question to end it. And we could hear what parameters should we use to evaluate the risk of SILI in maybe non-intubated patients?
The risk of what?
Of SILI, of self-induced lung injury.
Oh, the SILI. Yeah. Well, there are some simple ways and more complex ways. The simple ways is a good clinical evaluation. We should have a video recording of a patient. That's it. It's very important negative swings, because then the transpulmonary pressure is increased from the negative swings, and that can alter the lungs and promote the development of edema, of ARDS. It's terrible. So if you see that, you need to intubate the trachea and put the patient at rest, usually spontaneously. When you start invasive mechanical ventilation, the patient is tired from the previous dyspnea, the patient wants to sleep, and you may not have to give any sedative agent. If the patient continues to struggle and fight the respirator, try to change the conditions. Perhaps you could increase a little bit the tidal volume. Yeah. If the compliance is good, if the airway pressure does not increase so much, you could go to 7, 8 cc's per kilogram of optimal weight. So you could do that if the pressures do not increase very much. Okay. Now, if it doesn't help, if even with a larger, somewhat larger, don't take me wrong, I'm not advocating large tidal volumes. No. I'm speaking about 6, 7, 8 cc's per kilogram of ideal body weight. If it doesn't work, try pressure support. If it doesn't work, then you may have to use sedative agents. But you will first try to optimize the ventilatory conditions. And if it doesn't work, then you give sedative agents. Call me at the bedside before. I'd love to go with you at the bedside before. If you tell me that the patient is not well adapted to the respirator, we will look at it together. Because we may end up saying, okay, yeah, there is nothing else we can do. It doesn't take long. It takes 5 minutes to evaluate all this, and then we give sedative agents. But in the past, believe it or not, I knew my predecessor in our department who was giving orders in the distance. The nurse was coming saying, oh, the patient is fighting the respirator. Oh, yeah, give some, at that time it was Rohypnol, give some sedatives. Give some sedatives. And they was continuing the discussion with them. That's unacceptable. I loved him. He was a wonderful man. But that was the strategy at that time, the strategy of the bad intensivist. But things have changed.
Yes, especially after the Rose trial, we know that there's no need for deep sedation, even in ARDS patients. So, Professor Vincent, we thank you very much for this excellent webinar and discussion. We have more questions, but in order to keep time, we're going to have to we end the webinar now. We thank you again, and I hope to see you soon in Brussels. And please take care of all the ICU team at Erasmus. I always have them in my heart and remember them with a lot of love. Please give my love to all of them and take care.
Muchas gracias, Carlos. It has been a pleasure. Sorry again for yesterday. Take care of yourself. Okay. Good luck. Ciao, ciao. Bye.